Good evening, everyone. I hereby welcome you all, and we take great pride and pleasure in bringing you to this educational program, Advanced Classes in Dentistry. This program shall be conducted with our esteemed speaker, Dr. Hussein Basma. This educational program is brought to you by FDC Limited, makers of FlemiClav. Therefore, on behalf of FDC Proxima, greetings to everyone. As you know, FDC is a fully integrated pharmaceutical company. Today, FDC carries forward the flaming spirit of its first dream, achieving accreditations from the US FDA, UK MHRA, MCC RSA, and the UAE to cite a few. For over a decade, FDC is very strong in building capabilities of antibiotics, including the illustrious brand FlemiClav, a brand of co-amoxiclav. FDC has also set up globally approved multi-location manufacturing facilities for active pharmaceutical ingredients as well as finished dosage forms. FDC markets more than 300 products in India and exports many of these to over 50 countries. FDC strives to explore, innovate, and integrate solutions with modern technology, empowering talent and expanding healthcare horizons for a better quality of life to millions globally. Now I take the opportunity to introduce and welcome our esteemed speaker, Dr. Hussein Basma. Dr. Hussein Basma received his Doctor of Dental Surgery from Damascus University in 2009 with a full scholarship. Dr. Basma completed a residency in prosthodontics at Lebanese University and received a certificate in periodontology and Master of Science from the University of Alabama at Birmingham. Dr. Basma is a diplomat of the American Board of Periodontology, lectures nationally and internationally about periodontology and dental implants, and is a dental social media influencer. Dr. Basma is an assistant professor in the Department of Periodontology at UAB. His research and teaching efforts focus on bone augmentation, full arch rehabilitation, multidisciplinary care, and integration of technology. It's an honor to have him with us on this platform. I now request Dr. Basma to enlighten us on the topic of discussion today, osseous surgery. Over to you, sir.
Welcome everyone to this series of lectures that Aspirant is going to be conducting. And today's lecture is the first lecture in this series. We're going to be talking about osseous surgery, why, when, and how. And as Dr. Gulchin mentioned, I'm originally from Lebanon. I got my dental degree from Syria, and then I moved back to my home country, Lebanon, where I did a degree in prosthodontics. And then I moved in 2015 to the United States, where I did my residency in periodontology at the University of Alabama at Birmingham. And since that time, I became an assistant professor at the same department. And before I lecture, I always like to give some credits to the UAB team that allows me to represent them as I'm lecturing throughout and share with you some of the content. So big shout out for the UAB team. There's going to be a Q&A session and a discussion at the end of the lecture. However, if you got to ask me a question, if you got to say, oh, I wish I could have reached to Dr. Basma for one more question, please feel free to reach out through my social media that's only dedicated for periodontology, and through my Instagram account and through my email. So today's lecture is going to be again about osseous surgery, and that's going to be the outline of the lecture. First, I'm going to give you an introduction about periodontal disease. Then we're going to be talking a little bit about the treatment sequence for osseous defects. Then we're going to talk about fundamentals of osseous surgery. And we're going to share all this information that shared with you in a clinical case discussion. And we're going to finish with a conclusion and some questions. Again, that's a 40-minute. Usually I give this lecture in a 2 days component. So I try to summarize it to a level that I keep you entertained and share with you some valuable information. So we all know that our biggest enemy in the mouth is dental plaque, right? In normal health, we have some bacteria that's usually present in our mouth, and those are called the gram-positive cocci. Those are present in a daily basis. However, in some cases where those bacteria start shifting into a bad bacteria, we call them, okay, it happens when we start missing oral hygiene, when we start having some medical problems. In this case, as we all appreciate that there is a lot of local factors in the presence of plaque, in the presence of calculus. So the difference here between health and this case right here is that we have a lot of local bacteria that shifted from gram-positive into a gram-negative. So I always like to call them the gram-negative. Those are the bad guys. When I say bad guys, that means those have all the bad virulence factor that allows the body to have a severe reaction towards those bacteria. So what happens if we have poor oral hygiene? So basically, whenever we have poor oral hygiene, we will have a lot of accumulation of plaque. We will have a shift from the bacteria that we're having into a very virulent bacteria. And what's going to happen to the body, as any infection that could happen, the body is going to start to defend itself. And how usually the bacteria that's going to be present around the teeth is going to secrete, is definitely having some antigen, is definitely having some lipopolysaccharides. What are these? Those are the virulence factor that I've been talking about. So the body is going to start to defend against those antigens and against those lipopolysaccharides by secreting the polymorphonuclear leukocytes, by secreting neutrophils, by secreting the antibodies, okay? And when this happens, the body could win or the body could lose, right? For any infection. At the end, if you give adequate treatment, the body will win. But there are some scenarios, such as genetics, for example, especially in African Americans, where they are more susceptible to have some kind of aggressive periodontal disease. And we all agree on that. And also there are some environmental factors, like if somebody is a smoker, if somebody has an uncontrolled medical condition such as diabetes, we know that that will affect the healing a lot. And this will create a severe reaction from the body, from the host immune response, and the body is going to start secreting some markers that we call them the pro-inflammatory cytokines, the prostanoids, and the matrix metalloproteinase. So what are these three? These three actually are secreted by the body in response to the microbial challenge. And when those are secreted, the body is going to overreact, and then this will cause bone loss, and this will cause connective tissue loss, and that will lead to attachment loss. So as a summary to all of this, we have a bacteria and we have the body, okay? If the bacteria is very strong, the body is going to send a strong reaction, right? And then what's going to happen, all the factors that we talked about, if the patient is a smoker, if the patient has a genetic factor already that he is susceptible to periodontal disease, the body is going to overreact and is going to start sending all the markers that leads to bone loss and to attachment loss. So basically, what leads to attachment loss in periodontal disease is not the bacteria, is the overreaction of the host response. So that's why, for example, some of you would say, well, I have a patient that never brushed his teeth. He has a poor oral hygiene. He always comes to me, but he doesn't have periodontal disease. And there's another patient who have excellent oral hygiene, but he has some deep pockets. Why is that? Now we understand that the patient who has a very severe reaction to periodontal disease, he has some factors that lead to this destruction. So if any one of us wake up in the morning with this kind of lesion, we will freak out. We all agree that we're going to freak out. And then what's going to happen? We're going to run to the emergency. Please, doc, I want to treat this defect. But what is very important is that this defect and what you see in the upper image that's showing the teeth, it's exactly the same defect. If we measure the surface area of the infected area that we're showing, it's exactly the same. Why? Because if we take a very close look at that case, this is a patient that presented with a chief complaint, I have a fistula on the upper left central incisor. We all agree that we see that small sinus tract there. So when I initially look at this patient, okay, I said, okay, maybe this tooth is having some problem. Okay, and I can appreciate that there is a presence of calculus, there is presence of local factors, but there is not much plaque. So I told the patient, you know what, let's take an x-ray and we are going to check what's going on. I kid you not, I promise you guys, this is a 21-year-old guy, 21. I took an x-ray and I was surprised with how much bone loss we have around all his teeth. So this is a patient who is 21 years old, who has limited, I would say, yes, he has poor oral hygiene, but I didn't see much of plaque, but there's a lot of calculus. That means that the patient is definitely having poor oral hygiene. But with him being 21 years old, with this reaction, I can know that this is a patient that has an overreaction to the bacteria, to overreaction of his body towards what's going on. So he ended up losing a lot of his teeth. But look at the calculus. Calculus is all the way up to the apex. So periodontal disease is a disease that will keep on progressing until we lose our teeth. So we have to educate the patients about the importance of doing good oral hygiene and what is periodontal disease, right? So again, what's going to happen, as I mentioned before, the attachment loss is going to happen, and then some bony defect is going to start happening. Why? Because the body is going to try to resorb the bone to run away from that lesion, right? So if I go back one slide, so definitely we all agree that calculus that you see on any of these teeth, the bone is going to be far away. Why? Because the body wants that bone to be away from all the local factors, because trying to protect it. So what we usually do is we do scaling group planning in order to decrease the amount of calculus that we have. However, there is a lot of limitation to scaling group planning. Okay, in some cases, we have the furcation involvement. The width of that furcation, especially in the roof area, is very narrow. That doesn't allow the hand instruments to go and clean those areas, right? Some intra-bony defects, those are very challenging to clean. If we have very deep pockets, it's going to be very hard to reach out the depth of the pocket and then make sure that the whole pocket is clean. Multi-rooted teeth, especially if we have severe undercuts like the maxillary, first premolar, it could be a problem. Root anatomy is the same. If we have any kind of like an enamel defect, a cementum defect, that could lead to more problems. So what we have mentioned, as we mentioned earlier, we end up with defects in bony defect that are completely different from each other, right? We might end up with a two-wall defect, and that's called the crater, and that's what we're going to be focusing on today, due to the fact that this is the defect that we always do osseous resective surgery. Or the other option, we might end up with a three-wall defect. Those narrow defects that are usually well contained, those are excellent for regeneration. And when we say two or three wall defect, please always keep in mind that we're talking about bony walls. We're not talking about the roots. So we have to make sure that when we're counting the number of walls, those are bony walls that are present. The root doesn't count. Or we might end up with a combination defect of both 2 and 3 walls. Also, this is a defect that we're not going to be focusing on today, along with the circumferential defects, because those are very prone to regeneration. So we might end up doing some regeneration, and definitely regeneration is one of the topics that we're going to be sharing in the future. So we have to understand the defect prior to execution of what's the best treatment. Because if we have a 2-wall defect or a crater, it's very easy to go with an osseous resective surgery. If we have more walls, that means we have more blood supply, then this is a defect that we can grow bone back. So understanding the defect is crucial for treatment. So if any periodontal patient presented to your office, okay, patient presented with a periodontal disease, you have to have a sequence for periodontal therapy. And when we have a sequence, is basically we have to have a phase 1 treatment that allows us to have a candidate who's ready for surgery. Like, for example, if a patient shows up in your practice this morning or tomorrow morning, and he has deep pocket depth, you're not going to move directly into the surgery. Why? He's going to have a lot of bacteria. He's going to have a lot of calculus, as you saw before. He's going to have a lot of plaque. He's going to have a lot of inflammation, which makes it harder for you in surgery to do what? To control the soft tissue. So phase 1 treatment, I always call it the disease control phase. I want to control the disease. I want to make this candidate ready in case he wants to have a surgery. So what is phase 1 treatment? Basically, phase 1 treatment is going to be composed of oral hygiene instructions. I want to make sure that this patient is having a good oral hygiene. Otherwise, we're not going to do surgery. The second thing, I want to make sure that he has a controlled medical conditions. I don't want to have any uncontrolled medical condition like diabetes. I want to make sure that the patient is healthy and ready to have treatment, and I don't want to compromise any of his health status. Okay, I want to make sure I'm having a good smoking cessation. We all know the effects of smoking on oral and periodontal health. This is going to compromise your surgery. One important thing is extraction of hopeless dentition. This is the time you're going to take the teeth out. When you're seeing the patient, first, you're going to take the teeth out because you don't want anything compromising your healing and making this patient ready for surgery, as I mentioned earlier. Occlusal adjustment is a big one because we know occlusal trauma could lead to mobility. Mobility could lead to what? Could lead to severe periodontal problems. So the overall thing here is trying to control the disease, but basically what we always call, whenever we're talking about periodontal therapy, we talk about scaling group planning, which is called deep cleaning. So in addition to deep cleaning, we have to do all what I mentioned. Okay, so after we do the deep cleaning, after we already talked to the patient about all the oral hygiene instructions, we are going to see the patients for phase 1 evaluation, trying to make sure that our phase 1 treatment was successful. And we like to see the patient at 4 to 6 weeks. Why 4 to 6 weeks? Is because the soft tissue is the best, is having a good healing time. For after we did the scaling group planning, the patient is having the best compliance after all the oral hygiene instructions. So now it's time to do phase 1 evaluation. And when we do phase 1 evaluation, we are taking the probing depth again, right? We check the pockets. If we don't have deep pocket, then this patient can go into regular maintenance visits, right? But however, if the patient present after you do the deep cleaning with deep pockets, now we have to go into surgical phase. And depending on the type of defect, the osseous defect that we already talked before, we're going to try to choose if we're going to have osseous resective surgery or osseous regeneration surgery. Okay, so again, osseous resective, from the name, I'm trying to remove bone. Regeneration, I'm trying to add bone. So, and after this is done, the patient is we're gonna evaluate, we're gonna take the measurements again, and we are going to see if we still have deep pockets. If not, most of the time we're not, because that's when we have more predictable results, when we're doing osseous resective or regeneration, and then we move into maintenance at the end. So this should always be like, if there is one thing I want you guys to take from this lecture today, is this slide right here. Okay, always start by controlling the disease, and the disease is still present, you move into surgery. But no matter who is the patient, we should always end with maintenance visit. So what is osseous surgery? So osseous surgery is defined as the procedure of which changes in the alveolar bone can be accomplished to rid it of the deformities included by periodontal disease process or other related factors such as exostosis and tooth supra-eruption. What does that mean? Let me translate this. Basically, if we have periodontal disease, basically for any reason, we have a tooth structure or we have a bony structure that is actually not considered normal, we are going to do the osseous surgery in order to make this bony architecture a normal or a positive architecture. And this is very important to understand. But before we move into the positive architecture, I want you guys to think about, or to always remind you about, we have two kinds of alveolar bone, right? We have the bone that's you see on the yellow arrow that in the upper right image, that is called the supporting bone. So basically, this is literally supporting the tooth. So basically, it's immediately in touch with the tooth or is separated by the periodontal ligament. And what you see in the red arrow is called the non-supporting bone. And there is a reason why I'm reminding you about this. Because if we remove, as I mentioned earlier, the supporting alveolar bone, if I take that supporting bone out, that's called ostectomy. If I remove the non-supporting bone, that is called osteoplasty. Okay, why I'm talking about this? Because whenever we are trying to change the bony architecture, we are going to try to remove the bone around the tooth, and we're going to see that in just a little bit. So if we remove, as you see in the top right image, the bone that's very close, that's literally supporting the tooth, that is called ostectomy. If we remove the bone that's away from the tooth a little bit, that's called osteoplasty. Why do we usually remove bone? Is basically to create something called a positive architecture. So what is a positive architecture? If you look at all those three images, we all agree that the architecture that we see right here, we are seeing that the bone margins on the interproximal area is more coronal to the bone margin on the buccal or on the palatal area. So if we look at this right here, again, let me repeat this. If we have a bone peak on the interproximal area in between the teeth is higher than on the buccal and or on the palatal, that means this is our positive architecture. That's what our goal ideal should be. Okay. However, there are two other architectures that can be present. A flat architecture, which also is a normal architecture in some cases, especially in the posterior teeth. And we have the negative architecture, or what's called the reverse architecture, which could happen in cases where the bone level at the interproximal is lower than the bone level on the buccal or on the lingual. So what does that mean? That could mean that there is a problem here, and we have to change or do something in order to move that negative architecture into either flat or positive architecture to avoid problems from happening. And this is an excellent example to show you the difference between each. Let's look about the first image, clinical image that you see on the right. Okay, you can tell that the interproximal bone is higher than the buccal bone, right? You can, on the second image, you see that it's flat, all at the same level. So both flat and positive architecture, that's what our goal should always be. And then we have the negative architecture, which is basically, you can see that the bone on the interproximal is lower than the buccal or on the lingual. This has to be corrected. And that's exactly what I'm talking about. So if I remove the bone away from the tooth, that's called alveoloplasty. If I remove bone that's touching the tooth again, that's called ostectomy. Osteoplasty and ostectomy. Okay, so whenever we do osseous surgery, it's indicated for pocket reduction, which is for periodontal disease, or in some cases where we have to do crown lengthening. And this is again another topic that I'll be sharing with you in the future. So we do osseous surgery whenever we have active periodontitis, whenever we have deep pockets, whenever we have mild to moderate bone loss, and whenever we have existence of osseous defects. As I mentioned with you, we have some negative architecture, as you see in this image right here on the second molar. We have to change that in order to become positive or flat architecture. If this happens, then that's exactly we met our goal. So in mild to moderate defects or mild to moderate bone loss, we can be able to achieve that. However, in severe osseous defect, what might happen is that we can accept something called a compromise. Because if we correct the bone defect to have a positive architecture, we could literally remove the bone on adjacent teeth, leading to destruction or of more attachment loss. So we can say, well, we have to accept a compromise in those cases. We end up with pockets that we have to maintain more often. So if it's a mild to moderate bone loss, which we're talking about 1 to 2 wall craters, it's very easy to fix that problem. When we have severe bone defects, then here we have to accept a compromise. And when we say we accept a compromise, that means sometimes we end up with a smaller negative architecture and trying to avoid more bone removal on adjacent teeth. However, osseous have some contraindication, osseous surgery. Okay, if we are doing osseous surgery for anterior dentition, we are exposing more root surface. This could cause more aesthetic problems. Okay, if the patient has poor oral hygiene and you do a surgery, because we are exposing roots doesn't have the defense that the enamel has, you might end up with root decay, and this will cause sometimes tooth loss. So we have to make sure that we don't do surgery on patients who already have poor oral hygiene. Okay, some anatomical limitations, especially in the posterior mandible. What do we have there? We have the external oblique ridge. Most of the time, that ridge is a little bit high, so placing the tissue more apically, that could cause a problem. If there is a tori, then that could be a problem. We have to remove that, because the purpose of this is to apically place the flap in order to get rid of the pockets. Okay, so the whole purpose of the osseous surgery is definitely to give the patient a better access to clean. Why? Because think about this. If you have a tooth that has an 8mm pockets, what do you have there? You have a soft tissue pocket that preventing the patient from having an access to clean that area, because we all know that if a patient brush, the maximum he can go underneath the gum of the gingiva is 1mm. So if you have a 7mm pocket, you have at least 6mm that the patient is not going to be able to clean. So we have to make sure we're going to cut that soft tissue in order to give the patient access to those areas to have them clean. Okay, definitely osseous surgery will allow us to expose the roots to have better cleaning, will expose the bone to change the architecture into flat or positive architecture, as I mentioned before, right? If we have any bony defects, we are going to shape that. If we have any kind of osseous architecture like a tori that's present, we have to shape that to allow better adaptation of the soft tissue. And then definitely we are talking about pocket reduction and improve the soft tissue health and contours. So again, the whole purpose of osseous surgery is to have subtractive process. What does that mean? Like those areas that you see on the left that are considered to be pockets, we're taking those out. That excess tissue, we're taking that excess tissue out. We're shaping the osseous architecture to end up with the image on the right, with a scenario that gives the patient a better access to those areas that were already covered by soft tissue. How does that happen? By two things: by gingivectomy and by osseous reshaping. So if you look at the images on the left, we start by subgingival incision. And this is very important to understand. Whenever we do a submarginal incision, it has to be in areas where you have adequate keratinized tissue. In areas that you don't have adequate keratinized tissue, you end up doing intrasulcular incisions. So intrasulcular incisions is whenever you don't have enough keratinized tissue. Submarginal incision is whenever we are having enough keratinized tissue. So what's the difference between intrasulcular? Intrasulcular is basically when you go with your blade inside the sulcus, trying to preserve as much soft tissue as possible. Submarginal incision, as you saw in the upper left image, you can tell that I'm cutting away. I'm doing my incision away from the gingival margin, trying to remove that portion to give more access to the area that were hidden underneath the soft tissue. And then once we do that, we open a full thickness flap, and then we shape the defects, the bony defects. How do we shape the bony defects? Is literally using those burrs. Okay, on the left image, you see this is called the end cutting burr. We use this in order to do ostectomy. Basically, we are removing the bone that's supporting the tooth with an end cutting burr. We do some fine cuts there in order to move that buccal margin of the bone that we mentioned before, that's higher than interproximal. We move it more apically. And then we use the round burrs for osteoplasty in order to shave the bone and try to end up with a knife edge incision. So the steps for osseous surgery starts as such. we have to remove the bulk of the bone that's present there. If the tori is present there, and then we have to do vertical grooving, as I'll show you in just a little bit. And as you saw on the image on your left, on your right, okay, we then do some radicular blending. We flatten the interproximal bone, and then we gradualization of marginal bone. So let me show you exactly what I'm talking about. Okay, so we bring again, we said the first we're going to remove the bulk of the we are going to remove the bulk by using those round burrs. Okay, if we have a tori, we are removing this tori with the round burr. I don't use this carbide. I like to use the diamond burr, big diamond burr, round burr. And then it's on a high speed, and I start doing the osteoplasty. Why? I want to get rid of all this tori in order to allow to better adapt the soft tissue on the bone that I'm creating. Once I take that tori down, that's how the bone is going to look. And after I remove the bulk, I move into the second step, which is basically trying to remove those wide defects that are already created using a chisel or using the burr that I showed you before, the end cutting burr. Okay, and then what I'm doing right here, I'm doing the ostectomy. Basically, I'm trying to remove the supporting bone that I showed you before. Why? In order to move that bone a little bit more apically in order to achieve a flat or a positive architecture. And when I'm done with that, I just literally do some refining in order to have no bony peaks, in order to make sure no sharp edges I left or no irregularities. So you end up with having this amazing architecture right here, and this will create a better adaptation of the soft tissue. So if we move inside the mouth intraorally, you are going to see that's what I'm talking about. If you can appreciate here, the buccal bone is more coronal than the interproximal bone. So that's a problem, and we have to work on these defects in order to move those margin. As you see in this image right here, the buccal margin is more apical right now from the interproximal. So let me finalize all of this because I have 7 more minutes with this case. Okay, this is a patient who is 64 years old, presented with a chief complaint like, I always bleed when I'm brushing my teeth. So this is a patient, that's how she looks. We have tons of local factors. Please appreciate the amount of calculus that's present inside in the interproximal area. And we have a lot of bone loss. If you look at that premolar, we already lost that tooth due to periodontal disease. So what is the plan? This is the pockets. Those are the initial pockets that when the patient first presented. We have up to 16 millimeter of attachment loss. The patient is having a fistula on the upper right side, okay, on that premolar. Please look at and appreciate the amount of local factors, the amount of plaque, and the amount of swelling and inflammation that the patient is having on all around her dentition, okay? The anterior teeth also have a lot of local factors, also have a lot of inflammation in the tissue. Definitely, as I mentioned before, we cannot do surgery in this condition, right? Look at the upper left side, okay? A lot of inflammation, a lot of plaque, a lot of swelling, right? So a lot of deep pockets, okay? So we have to make sure we are registering those numbers when the patients initially present to our practice, because those numbers that we are taking are going to be what our reference throughout the treatment plan and the treatment. Okay, so this is how the patient presented again. So as I mentioned before, we have to follow that treatment sequence that I mentioned before. I have to do phase 1 therapy. Why? Because I cannot proceed into surgery with all those conditions. I want to make sure that the patient is start to develop good oral hygiene. I want to make sure that the patient is going to have a better tissue quality to be easier for me to do the surgery. I want to make sure that I removed most of the local factor and the calculus that's present, and then I will have more predictable results. So what we did is actually we did scaling group planning, deep cleaning, and please appreciate the difference. The left image is going to be before the scaling group planning. The right image is going to be after scaling group planning. Please appreciate, take a second to look at all the differences. Now look at the tissue quality. Look at amount of recession that we had just from scaling group planning. Notice the papilla in between the centrals on the upper and on the lower. You see how much inflammation we have decreased, right? Now the patient has better oral hygiene, less local factors, definitely better soft tissue quality. Definitely I can now proceed to do the phase 1 evaluation. That's the lower lingual surface of the mandibular. That's the lingual surface of the posterior mandibular teeth. You can appreciate that the tissue quality is better, but we still have some areas that you can tell, as you tell in this molar, it's still bleeding. When we have bleeding, that is a problem. That means we still have problems that we have to take care of, right? So the same here, local factors are taken care of. We have immediate change in the quality of the soft tissue. Here, where we have the maximum amount of probing depth, you can still tell that the soft tissue is still not happy, right? So, and that's how the soft tissue is changing on the right side, and that's how it's changing on the left side. So now we can tell. Let's come. We ask the patient, please present to our office. We're going to take those measurements again. When we took those measurements, although we have some good recession, although we have some good quality, but because of the bony architecture, because of how deep are the pockets, we have to do phase 2 therapy. Why? Because we still have deep pockets that we need to take care of, right? So then we move into the osseous surgery. I'm going to take a quadrant of this patient. I'm going to share with you due to limitation of time, and I'm going to show you the final outcome, and then we're going to wrap up this session. So again, whenever we are looking about osseous surgery, again, I'm looking about first the incision design. If I look at the buccal, I can tell that if we have enough keratinized tissue or if we don't have enough keratinized tissue. If we have, to repeat that, if we have enough keratinized tissue, we're doing submarginal incision. If we don't have enough, we're doing intrasulcular. So basically, in this case, because we have the palate is all keratinized, we are going to do submarginal incision, and the same on the buccal. Basically, we open a full thickness flap, and that's the soft tissue that is occupying those bony defects. This is literally before we open or before we start working on the bony defects. Okay, so what's going to happen? Those soft tissue, we call them the granulomatous tissue that's present in those defects. We're going to try to clean everything out once on the buccal and on the lingual. Okay, once we do that, you will have a better appearance of the bone, where you're going to do osseous resection, where you're going to do osteoplasty, ostectomy. Here you can tell on, for example, on the molar, on the second molar, that we have a crater that we have to take care of in order for us to have a flat or a positive architecture. In this case, we have a very deep pocket, so we said we might accept a compromise. So that's how things are looking on the lingual. Exactly, we follow the same sequence. We do osteoplasty, ostectomy to remove, osteoplasty to remove the bulk of the procedure. Then we do the radicular grooving, and then we find the bone. Then we do ostectomy to achieve a positive architecture. And then after that, the patient is ready to suture. We like to use those non-resorbable sutures only if the patient has good oral hygiene, only if the patient is going to show in 1 week. Why? Because this suture, which is called silk, is a non-resorbable suture. It is excellent handling, but it has a lot of local factors absorption. So basically, those local factors are going to adhere to this tissue, to this suture, and it will cause more problems. So before I use this suture, I always like to ask my patient, do you want or can you come for a 1 week follow-up? If he say yes, then we can use the suture. If no, I would personally prefer to use a monofilament, which is basically don't harbor bacteria. Okay, that's how the patient look. You can appreciate how much soft tissue we have removed. Now we have more soft tissue, more tooth structure that's showing. Yes, you can tell that, Dr. Basma, you already created recession. Yes, in this case, I am creating the recession in order to give the patient a better access to clean those areas. That's how the patient comes at 1 week, and we remove the suture, and that's how the patient is showing now. Please appreciate how the soft tissue is beautifully pink, how those areas now are easier for the patient to access with the interproximal brushes to clean, and how healthy is the tissue all the way around. So now the patient, if the patient wants implants on the upper right side, that's going to be the time where we move into implants. So what does that mean? If the patient presents to you for implants and there is periodontal problems, you have to take care of those problems before you place the implants, because treating teeth with periodontal problems is way harder than treating implants with peri-implant problems. So we don't want that to happen, and that's what we have to do after we're done phase 2 evaluation. Everything is looking great. There's only one area that we accepted, or 2 areas that we accepted a compromise, and that shows you the difference between the initial when the patient first presented, and then 4 weeks after, and then 4 months after therapy. That shows you how how we progressed with having less deep pockets now. Now it's time to put the patient on a 3-month maintenance visit in order to try our best to preserve or to maintain and prevent any future progression or progression of periodontal disease. As a summary for all of this, always try to understand the defect. If you have a defect that is too wall like a crater, and this is a defect that you have to go with osseous resective surgery. If you have a defect that has more bony walls to it, then could be better for regeneration. Okay, the earliest that you find periodontitis, that is the time that you're going to have a more predictable outcomes. The more you wait, the more progression is going to happen, the harder it is going to be to treat those patients. The definite goal of osseous surgery is to have a better gingival scallop and to have to create a flat or a positive architecture. In severe cases, we have to accept a compromise, otherwise we're going to be causing more damage to adjacent teeth. So keep those things in mind, know the sequence, always start with a scaling group planning, always start with disease control, prepare the patient to a surgery if he is going to be a candidate for the surgery, and always, please, always end with maintenance. Maintenance is basically seeing patients every 3 months. If this happens, we are definitely saving the patient a lot of headache and saving the patient a lot of possibility that he's going to lose his teeth. With that, I want to thank you, everyone. I hope I was on time, and I open the podium now to questions.
So how effective is osseous surgery in treating cases with deep intrabony or hemiseptal defects?
Yes, so this is an excellent question. Again, whenever if you have a bony defect, no matter how it is deep or shallow, you have to make sure that you're taking care of that bony defect. In some cases, if it's shallow, again, the purpose is to achieve a positive or a flat architecture. In some severe cases, if we can still save the tooth and we can accept a minimal compromise, like we can achieve a minimal reverse architecture, we can definitely take care of that. However, in cases that I might think a step forward, if I have a deep pockets or a deep bony defect, if I take care of this defect, is going to compromise adjacent teeth, I would mention that to the patient, and probably I would, in some cases, not all of them, I will try to take this tooth out in order to prevent more compromise to those patients, to those adjacent teeth. However, if the tooth can be savable, but on the mesial or on one side of the tooth is going to be predictable to achieve a positive architecture, but the other side it's not going to be, I try to always accept a compromise. But however, no matter what defect it is, we have to take care. If we have a bony defect, we have to make sure we're taking care of that.
So the next question that we have, Dr. Basma, is how do you select cases for flap surgery? What are the criteria and indications for these kind of surgeries?
Any patient that has deep pockets, especially after you do scaling group planning or after you do deep probing depth, definitely should always be a candidate for osseous surgery. The whole purpose is to remove those pockets. If there is another name for osseous surgery, it's called pocket elimination surgery. Basically, we're eliminating the pocket. Why? Because the tooth or the soft tissue that's covering the tooth that's creating the pocket, if it's still there, the pocket is filled with bacteria. The bacteria is gonna grow and grow and grow, leading to more destruction. So I have to create an environment that's not suitable for the bacteria to grow. How do I do that? I will cut the soft tissue to a level that I respect the biological width at the same time, and allow the soft tissue to heal in a good way. Why is that? Just because if I don't give the patient, or I don't remove those gingival tissues, the patient is never going to have access to clean those areas. If, for example, I opened the flap, I did osseous shaping, and I close it back, the pocket is still there. Right? The pocket is still there. Then the bacteria is going to start to refill again, and the bony problems is going to start to occur. So I want to create an environment that doesn't allow bacteria to grow, and at the same time fix the bony architecture.
Yeah, so basically we do not stop with the surgery. We have to take care of things after that also.
Exactly. So always make sure that you have, like, for example, for example, just to give you an example, like patient is having all those factors. If I go into surgery immediately, it's going to be impossible or very hard or harder for me to manipulate soft tissue, right? It's going to inflamed, and you guys are surgeons, you know that it's going to, if I want to suture through inflamed tissue, the suture is going to rip easy. So that's why make the soft tissue heal better. So basically do the scaling group planning, have the patient good oral hygiene instructions, and come back when he ready for a candidate. Like, for example, sometimes a patient would come to you, I want full implants on the top, full implants at the bottom. If you want to think about this instantly, that's a lot of money, right? But the thing is, maybe he's a smoker, or he has an uncontrolled medical condition. So, for example, in those cases, I will send the patient, I was like, listen, I want a consult. I want to know what's your HbA1c is. If it's more than 8, we're not doing the surgery, sir, because everything I'm going to do is going to fail, is more risk to fail. So let's control the A1C and then come back. Once this is controlled, now we'll talk about restoring your dentition. Okay, so it's exactly the same. If he has poor oral hygiene, we're not going to go into surgery. We're going to give it sometimes before we do into surgery. Exactly like if a patient shows for dental implants and he has periodontal disease. A lot of time we had hard time convincing the patient, like, hey, listen, before we do that tooth that's number 18, for example, we have to make sure that we do scaling group planning. We have to do osseous all the way around. We have to take this tooth out. But he will say, oh, I am come here for this tooth. But sir, if you place an implant in this environment, what's going to happen? Bone loss is going to definitely occur around the implant, and that implant, once it have bone loss, now the treatment is going to be more or harder or less predictable. So that's why we have to create a patient that's suitable for the surgery before we proceed to surgery.
Absolutely. Take a holistic approach towards the company. Great. So another question that we have, Dr. Basma, is that in terms of surgical outcomes of periodontal therapy, is there a difference with and without initial scaling and root planning?
Of course. And this is what I just mentioned earlier, is that if you don't do scaling group planning, I'm not saying that your surgery is going to fail. No, you're going to have a hard time manipulating your surgery. You have to do scaling group planning in order to make the soft tissue heal before you progress into the surgery. There is definitely a lot of studies, that old studies, actually nobody is actually publishing on this topic, because this is an old topic, and it's like we have published everything about this topic, nothing new, right? So the thing is, if you have to go in surgery, or the difference if you do scaling group planning and the difference if you have osseous alone, especially in moderate to severe cases, a lot of literature have supported that osseous surgery have a long-term better outcomes compared to scaling group planning. So that's why we should always, in cases where we have moderate to severe pockets, we should always move into osseous surgery. But again, we go back to the earlier question. We have to prepare for the surgery.
Okay.
How do we prepare is definitely scaling group plan.
Right. So this question is related to crown height. So what the person wants to ask is, how can clinician establish proper crown height during surgery?
Okay, crown height is, there are several ways to, and this is out of topic, and this could be another topic.
This is out of topic, absolutely. So I in fact, we have another question which is out of the topic, but I'll still ask you. That's an interesting question also.
Please.
Yeah,
in order to achieve the crown height, there are two ways, okay? So first of all, we can follow the ratio, okay? Let's say we have a central incisor. It is width, let's say it's 8 millimeter, okay? How do I know what's the height? I can tell you from now, there is literature that supported that the crown, the width and the height are at a ratio of 80%. So let's say if the width of the central incisor is 8, then the height is going to be around 10. And this has been, like, they have done a lot of means and they have found that it's an 80%. This is one. Number two is trying to check where the CEJ is, because that's the margin, that's the level where the CEJ is going to be. If the level at the CEJ is, if the tissue is at the level of the CEJ, that means we're good. And again, if the level, so also we have some gauges that is called like the shoe gauge that literally showed you the width and the height, or the width and the length of the crown. This will also tells you predictably. Another thing that could be also an option in cases where we have non-carious cervical lesions, where we want to check where the CEJ is try to compare with the teeth from the contralateral sides. Like, for example, if we have a tooth that's messed up on the right, if the tooth on the left is not messed up, then we can use that as a reference to gain the height. So it's different scenarios, but definitely the easiest way is try to go with proportions, which is the 80% that we talked about.
This is a general question, not related to this, but one of the doctors want to ask, how do you assess blood loss in such surgeries? Maybe he has faced some challenge in certain patient. So that's, how would you assess a blood loss in such surgeries?
Blood loss in surgery, like, it's nothing, it's not, because of the limited area that we're dealing with and because of the finite or very small arteries that we're dealing with,
right,
blood loss is not a big problem for us, unless
typically it's not a clinically relevant factor. But maybe there has been some question he has in.
Yeah, it's definitely not clinical relevant, but I'm not saying about those bleeders. Sometimes because in the roof of the mouth, whenever we're harvesting a soft tissue, we have a bone, like an artery that we might hit. It's easier to control. It's very easy to control. Basically, it's either you put some numbing, it's either that you sutured that artery. So it's bleeding in the oral cavity is never life-threatening. Unless you hit major arteries like in the floor of the mouth, yes, that's a problem. But other than that, it's controllable.
Okay. So the next question that we have is, Dr. Basma, would you recommend dressing in chronic, moderate to severe generalized periodontitis requiring periodontal flap surgery? Would you recommend dressing in periodontal flap surgery with chronic, moderate to severe periodontitis?
I think, yeah, definitely dressing is a good, that's an excellent question, actually. I personally maybe done like 5 or 6 dressings in my whole career so far, but dressing is very helpful whenever you don't have or when you want to have a really good apically positioned flap. This is definitely, what does that mean? Basically, if your sutures, even though you have a tight suture, you are literally, the soft tissue is not placed apically in order to remove that pocket. So what I do in this case, yes, I would put a dressing, try to push the tissue down, and that dressing is going to hold the tissue apically in order to prevent the soft tissue from kind of traveling again all the way coronally. So it's very important that we use the dressing in this cases, but it's very minimal, because if you have if you understand what I mentioned, what I talked about, if you guys understand what I mentioned, it's gingivectomy whenever you have keratinized tissue and intrasulcular whenever you don't have keratinized tissue. If you follow this sequence, if you don't do submarginal incisions, it's going to be harder for you to apically position the flap sometimes. That's when I use the dressing. In cases where you are doing submarginal incision, this should never be a problem. But a dressing is an excellent thing to use. If you use it every day, I would say that's an excellent practice, definitely.
Great. So because of paucity of time, we'll just take one last question, Dr. Basma. So this is again a very important, but yeah, a general question. So they are asking that in post-surgical clinical monitoring, what are the key indicators or signs to look for seeing that the soft tissue is healing well, in terms of soft tissue healing?
In terms of soft tissue healing, like after surgery, you mean?
After surgery.
I look at the surgery. I want to make sure that this, like, definitely, if you're talking about short term or long term, let's talk about both.
We can divide both, yeah.
Short term, I want to make sure that depending on what surgery I'm doing, if I'm doing some grafting, I want to make sure I have some, we call it primary intention, which is basically we don't want the soft tissue to be open. Okay, I want to protect what I'm grafting. So this is number one. I want to make sure that my incision is still not open, is closed, right? Also, I want to make sure that there is no signs of infection. So basically, I try to gently press on the soft tissue. If there is pus, then definitely that's a problem. That means that there is something there that's not working. So maybe here I should reconsider doing other stuff. The other thing is definitely at 2 weeks, you might still have some inflammation. You must still have some swelling because of the surgery. At 4 weeks, this should start gradually removing. Most of the surgeries, other than soft tissue, the sutures can be removed at 2 to 3 weeks. Okay, soft tissue, we usually like it for a longer time. But the science is basically in an osseous surgery, you should see that the tissue is apically positioned. That's number one. In the soft tissue is pink. There is no redness after a long term. Okay, once we see that, there is no bleeding on probing. If we see bleeding on probing, that means that there's a problem. So those are the signs of successful surgery.
Sure. That was very informative, Dr. Basma. So I'll pass on the baton to Dr. Gulshan now for a word of thanks.
Thank you so much, Dr. Manish. Well, with this, we come to the end of this very educative and interactive session. And I'm sure the audience would have gained a lot from today's discussion. A big vote of thanks to Dr. Basma for sparing his valuable time and being with us and educating us on this topic. I would also like to thank our educational partners, FDC Limited, and CME partners, Parent Communication, for conducting the program. Happy weekend to all until we all meet next again. Thank you so much, Dr. Basma.
Thank you so much.
Thank you, Dr.